I think we're really early on our path toward transformation and disruption. And so the hope of the day is you get a sense from really some world-leading speakers, what's happening, why it's happening, where life is going to take us, and leave with a sense of a little bit of disquiet, because there's going to be a lot of change, but also some optimism that we can actually reach a better place, and that's the goal. So with Andy, I thought we would best divide our time half COVID and half sort of non-COVID and the system beyond COVID. Is that all right?
Half monkeypox?
No, very little monkeypox. And by the way, Andy, you had COVID a couple of weeks ago.
Yes, I did.
I assume your rapid test is negative because here I'm sitting next to you without a mask.
I'm all good.
Good, okay, terrific.
Never better.
All right, so welcome, thank you for coming.
Great to be here. And I came here a big admirer of Bob's. I think Bob's what I call a healthcare citizen, meaning you don't just think for your institution or for yourself. You do a great job thinking on behalf of everybody. But now I'm a big fan of Richard's because I think for any of you who've had to do what he did this morning, this sort of almost Renaissance person's perspective on healthcare from high to low, and, with data, with truth, with objectivity, is a really good grounding. And I think, at its basis, the biggest pandemic we have going right now is probably misinformation, distrust, disinformation. And so I'm attracted, and I think we all should be, to reliable, high integrity people in conversations like I think you guys started. So hopefully we'll continue it.
Yeah, good. I think you called that right. I've learned a lot about leadership from working with Richard for now close to a decade, so you got to see a slice of it today. So you had COVID, you dodged it for 2.5 years, you had it a couple of weeks ago. What'd you learn from the experience of having it that you didn't know?
Well, I think a couple things. One is that, BA5 can find a hole in all of our stories. So there's the variants that are getting increasingly more clever, if you could put human terms on these variants. It makes it incredibly hard, unless you're going to live a completely risk-free existence, which, except in the most extreme cases, I don't recommend. I don't think any of us recommend. The second thing is that with all of the biotechnology that's occurred over the last couple of years, it is very different to have COVID today than it is 2 years ago. It's extremely different. We're talking about things like bounce backs. We're talking about very narrow optimization fields, as opposed to a couple years ago when we're talking about overcrowded hospitals and the like. And I think we are on a path where it will get increasingly like that. Still, I think, and I wrote a piece in the Atlantic last week, that we are in a rut. This relates a little less to me than to everybody, where we don't see how the path improves dramatically from here, and there's a couple of ways that can happen. And then I learned, as you know, that the practice of medicine on this is still very early, and there's a huge variation. And I went to a wonderful doctor who sees lots and lots of COVID patients, who prescribed me about 5 things, of which I think I needed one of them, and the other 4 were either. And I called Bob actually and said, Bob, hey, what do you think? I'm getting these things prescribed to me. I don't know whether they make sense. And you said in the kindest possible way, they don't make sense. Don't take them. And that was a bit of a surprise at this stage. And in fact, you and I just did an episode which we released yesterday with a checklist on, what actually the evidence says to do when you get COVID. And it's amazing how many people out there just don't know where to go and what to do.
Yeah. You mentioned that it's increasingly hard to hide. You're still being pretty careful, at least you were until you got it. Do you think that's a waste of time and energy at this point? And it's because a lot of people are fatalistic about this. A lot of people, maybe most of you, without the requirement, are going in indoor places without masks and sort of like maybe not even worth trying to dodge it. What do you think about that now?
Maybe one of the best things we can do is to adopt a posture of there's no wrong answers for individuals. I mean, look, if you're putting someone else at risk and you're being reckless, I think that's wrong. That's my own value judgment. But other than that, I think we ought to take a step back and stop saying, we got to stop with the sneering, stop with the dirty look, stop with she's wearing a mask, he's not wearing a mask, and arriving at value judgments. Let it go. I mean, a lot of relationships got damaged and broken, and it was a stressful time, so it's understandable. But we've got to let people protect themselves the way they seem fit. And if someone feels more comfortable wearing a mask, even if the evidence is that there's a very small chance they'll get COVID, or if someone feels like they don't want to wear a mask, even though it's a pretty risky place to be, increasingly we got people that are informed, they've got scientific options, and I think creating. So I think we ought to step back and refrain from a judgment. All these decisions are okay. And if you're going to run an event like this, it is completely okay to say, you know what, I want everybody to wear a mask. And if you don't want to wear a mask, that's fine. You don't have to be in the room. It's completely okay to do that. And it's completely okay if they said, you know what, we prefer to do testing, or we're not going to require you to take a mask. Then a lot of people may decide not to come. But I think, I personally think that the way the Doctors Company modeled their decision-making here is more important, because it models other people's decision-making. And so taking a step back, and I admire that. But I also think we have to be not quite so heated, not quite so judgmental as we continue to move on and allow people to figure out how to get back to normal and what's right for them.
Is that a change in your thinking about this? I mean, we're a year ago when you said something about them?
Since the vaccine, and then since the monoclonal and Paxlovid. Before then, I think it really was a different situation. Mm-hmm. It was a situation where we did a lot of people who didn't have the option to protect themselves. And you could argue until kids under 6 got access to vaccines, we were still in that spot. But nowadays, there are people that are going to say, you know what, I've got a 13-year-old kid, I don't want to vaccinate them, and I've thought about it, and that's perfectly fine, even if it's a decision you wouldn't want to make. There's other people who make different decisions, and that's going to happen. And as history will show, it'll take months and years for people's attitudes to evolve. Browbeating them, it's not the right way. I also think because the vaccine isn't as protective against spread, right, it does change the equation. And because we have high quality masks, where we can all protect ourselves, we can put ourselves in situations where if someone comes to me and says, there's something really important for me to do in my life, go to a ball game, visit my dad, go to a college graduation, go to a concert, there is probably a safe way to do it, mm-hmm, if it's important to you. And if you want to take risks in doing it, those are increasingly your risks. They're not risks you're transporting on everybody else. Yeah. I do think there's an obligation, if you get exposed, though, you got to take that seriously. You've got to call everybody you've been around. You've got to do a bunch of things. You've got to treat it responsibly. It is an infectious disease. But I do think the cost of, I'm not even talking about the regulations, just the cost of our personal judgments and our personal animosity here are something that it's causing more harm than good. Do
you feel the same way about vaccinations in terms of judgmentalness and trying to push people to get a booster?
Well, look, I was in charge of that for 4 or 5 months, and the best thing you could do is get people the information they need, try hard to get them to reliable sources that they trust, and allow them to hear from experts. Oftentimes that's a doctor, that's a pharmacist, that's someone else in their life, and get the facts. Mm-hmm. And so if someone chooses to get the facts and they get true reliable information, and they choose still not to get vaccinated, that's not something that we can force on people. But I do think it's important that everybody gets those facts. I do think it's important that in certain situations where you're going to be exposing other people, a targeted vaccine mandates are absolutely appropriate at that level. But there's 3 groups of people that I think have been having, been called out as being, unwilling to get vaccinated for one reason or another. Primarily, though, it's driven by age. I mean, conservative, liberal, yes, there's a little of that. There's all kinds of other factors. But show me a 90-year-old, I'll show you someone vaccinated. Mm-hmm. Show me a 5-year-old, I'll show you someone who's probably not vaccinated. And guess what? There's a certain logic to that, as you know. Yeah. So people are not as dumb as we think they are at assessing risks. Yes, there's regional variations and differences in rural and politics and all that. But in the end, in the main, it is largely driven by age. and to a certain extent, saying to a 20-year-old, you have to do this, you'd say it with a different level of force than you would to a 75 or an 80-year-old.
Mm-hmm. You were in charge of basically the country's communication when the vaccines rolled out, and it's been bumpy, and there's a lot of misinformation around. In retrospect, is there anything you or the federal government could or should have done differently, or is this just the nature of the world that we find ourselves in?
When you have shortages, you have hoarding mentality. So doctors were basically giving one and storing one, so when the person came back in a few weeks, they could have one, because there was no reliability and no predictability. And Pfizer and Moderna didn't know 1 week to the next how much they would produce. And people were getting frustrated, and the haves were getting online and driving to places where there were vaccines and getting in line and waiting all day and getting them, and people who had to work all day weren't. Mm-hmm. So that was the situation. And the president had one bit of guidance for me. That's it. He said, when you're talking to the public, I don't care how what you say reflects on me. What I care about is you give people information that helps them. Literally, that was all. That was all. And, this isn't a political conversation. The prior president was an important audience. Was an important audience for everybody who spoke.
Yeah.
How did he look? How did you make the administration look? So it was a lot of freedom to go out there. And the first thing I said was, look, we have a shortage. It is uncomfortable in this country to not get what we want when we want it. The shortage will last about 2 months. At the end of 2 months, we will have more vaccines than people who want them. And so, believe it or not, we are working now on an education campaign to help people understand that. But in the meantime, this is how we're going to deal with the shortage. And what I said did not feel extraordinary. Does not sound extraordinary. I had an outpouring from doctors, nurses, people saying, I feel like I just heard the truth. And I said, maybe I'm going to stick with that as if my theory is just tell people the truth. And the goal at the time was to try to beat Alpha. Because if you recall, we were just seeing Alpha in South Africa, and we were like, okay, something's coming. We got to get this out ahead of the country, or there's going to be another wave. Mm-hmm. And we did. We beat Alpha. What we didn't see coming, and didn't come till after I left, thankfully, was Delta. Mm-hmm. And I think where you can fault the administration is very few people perceived that there was going to be another variant that would come that would render all the vaccinations, put them in a different light, to say the least. What that did was a number of things, including make it appear that when we told people to get vaccinated and they'll be okay, right, that we either were not telling them the truth or didn't know what we were talking about. At moments like that, that's when you have to really be very candid and clear and honest with people. Yeah. I mean, there's national security language for this kind of thing, unforeseeable events, et cetera, but it starts to sound like excuses to people. Mm-hmm. And I really encourage public health experts and scientists to not continually say, hey, I did the best I could at the time. I did, because I think people will give you credit for that when you say, you know what, I didn't see this, now I see this, here's the guidance. I wish I'd have seen it. You don't have to say, was it foreseeable, was it not foreseeable? But if you want to maintain trust with the public, make sure the public believes you're giving it to them straight, not trying to protect yourself. And it's very hard to do that, particularly when you've got journalists and people in Congress and everybody on Twitter ready to lynch you for being wrong. But we identified 3 groups that were going to have trust issues with the vaccine: people of color, younger people, college age, and rural conservative. And the microcosm of that is where? The U.S. military, right? Not college educated, a lot of rural, a lot of conservative whites, a lot of people of color. And we saw that right away there. And what people cared about was people they knew locally, and being able to ask reliable questions of people they knew locally, and being listened to and not treated like a moron. Mm-hmm. So, it's very easy to sit in the White House on high and say, all these people are not getting it. That's the wrong answer. The right answer is, as you all do every day as physicians, Where are people? What are they thinking? What are their concerns? Can you listen to them? And at the end of the day, if you look to them like you have more of a stake in them getting vaccinated than they do, it won't make sense to them. It won't make sense to them. Even though we know public health, it's for the good of all, et cetera. And in each of these groups, we had church leaders, we had people in the conservative community who were incredibly helpful. And we just said, go have local dialogues. What information can we give you to help you have these local dialogues? And to some extent, I mean, everybody who trusted the government was already vaccinated, right? So everybody that was left were people who did not trust anything they would hear from the president or a pharmaceutical company or a scientist or someone in authority. They trusted their physician, they trusted their pastor, they trusted their neighbor. And let's face it, even though it seemed like a real urgent thing to do, for a decision like this, it's not unreasonable for people to say, I need to take some time to think about it. And you have to allow that time even when you're feeling impatient. And even though we knew that, you could sit here and talk to Tony Fauci and say, if we don't act more quickly, this next variant's going to come and people are going to be sorry. When it meets reality, telling that to people, you have to do this, and here's why, with that level of urgency, I think it violates everything we know about communication. Thinking about what Richard's slide about customer service and listening to people.
Let's move to the present. Sort of riff a little bit on the booster, the new booster, better boosters. Where do you think all that's going?
Well, so, to start with the virus, what we don't have now is a once-a-year mutation like we do with influenza. We have something that's circulating more like the common cold, where a new variant, we can see these new variants line up, as we talked about, like planes on a runway.
Yep.
And we can't make boosters that fast. So that is a predicament that we are not prepared for and not prepared to adjust to. So we are going to release boosters probably, at best once a year, new boosters. And if the formula is better or a bit better than the last one, it may only be better relative to what we saw in March when we built the vaccine, as opposed to what actually is there in October when the latest variant shows up. That's tricky. And I think it's incumbent upon us to be as clear as possible about the incremental benefits to each population of getting these new vaccines. I think a certain segment of the public feels like they were overpromised what the vaccines will do. Now, I will tell you that we've saved, 5-6 million lives across the globe with vaccinations. We've dramatically decreased hospitalizations. We've done all these wonderful things. But that's not how these vaccines were originally billed to people, and that's not how people hear them. So when we talk about these boosters, we should be thinking about the level, probably closer to the level of effectiveness and take-up that we do see from the flu, which is to say, there are a lot of people that are going to look at that and say, why should I do it?
It's not that great.
Right. Now, but there are target populations, nursing homes, school teachers, others, where I think we can say they're highly effective and highly important. And I think we need to explain to people that what the benefits of staying current are. Where I think this will end up, hopefully, is within a year or two, we will see the next breakthrough, which is probably a nasal vaccine, which can actually prevent you from getting the infection in the first place, be more easily administered. We've got, I think we've got 12 nasal vaccines in some stages of the trial, 4, I think, in stage 3. And if one of those pans out, then I think we do have something easy to administer and that can break through. But in the meantime, I think it's going to be a little bit of a slog.
Yeah, although listening to your podcast with Eric Topol made the point that even with nasal vaccines, you're still going to need the other vaccine on top of it, maybe less frequently, and maybe the nasal vaccine will prevent the infection in the first place, but you may need to get a spritz every 3 months, 4 months, 5 months, hard to know.
Yeah.
But probably not magic.
Yeah, and it could be you could take them prophylactically. It could be you take them after exposure. There's a lot of potential. But the nice thing about a nasal vaccine, if it works, and it's really going to be hard. The hard part is going to be figuring out whether they work, because you can't test your antibody titers in your nose.
Yeah, right.
So, but if you do find something that works, you don't need medical professionals to do it. The 10 to 15% of the public that I'm persuaded are highly needle phobic. I think a lot of people talk about why they don't get vaccinated. Very few people will say that they're needle phobic. There's a huge amount of data which says that that's very real. You can ship these across the globe, and if you can prevent people from getting the infection in the first place, that'll be a step forward. I don't think there's a step which gets us to this disappears, but I think if we get to a step which says I don't have to miss work or school for 6 days, and my life's not disrupted, and I can socialize, then people will get even more comfortable. In the meantime, I think we're going to be sort of in this incremental battle with the variants, and probably losing as much as we're winning.
Right.
Within the band. I don't see the death rate climbing significantly. I don't see hospitalizations climbing massively significantly. But I also don't see it getting a whole lot better until something else changes.
Well, you wonder, though, whether the virus and the variants and the are going to do this, but as a society, we're just going to increasingly lose interest. And that will obviously influence masking rates, it will influence vaccine rates.
I think it's already happened.
It's already happened, yeah.
David Ho, the great AIDS researcher, and I were doing a presentation together, and he made the point, exactly what you're saying, that the 1919 flu lasted well beyond the 2 years. But at the end of 2 years, society decided, we're done.
Yeah.
We're done.
Yeah.
And that was the capstone, that was the beginning, and that was the end. But he showed that if you keep looking, there was the continued phenomenon we saw out there. And a lot of the smart epidemiologists actually called this at the very beginning. They said there is an absolute limit to what the public will tolerate, even if this were killing many, many more people. There's still an absolute limit for people who feel safe, being willing to disrupt their lives, and it does appear that we've reached that. And I mean, people struggling for equilibrium, but I think we just have to always remind ourselves that just because you feel safe or I feel safe doesn't mean that everybody does. And there are still people out there who are very much at risk. 150,000 people dying in a year is not nothing. It makes it the third or fourth largest killer coming out of nowhere. I just had an elderly cousin that died from COVID. It's easy to take a deep breath when you feel safer. It's harder to remember that not everybody can take that deep breath, and they sort of count on us to be, at the very least, thoughtful. Doesn't mean we can't engage in life. It does mean we have to be sensitive when other people can't, and to try to help that when we can.
So maybe my last COVID question, and then toggle to the rest of healthcare. We haven't talked about long COVID. I've been struck, when my wife got it, and I thought I would, but didn't. My feeling was I'm not really worried about dying anymore with 4 vaccine shots in me, but I am worried about long COVID, and she ended up sort of still being exhausted 3 months out and with some brain fog and all that. Where does because you could say society feeling like I'm over it, partly quite rationally. Your chances of dying of it if you've fully vaccinated, by which I mean boosted, is quite low. Long COVID is sort of the big variable. So how do you think about long COVID in your own personal behavior and as a policy issue?
So, really hard to calculate. Well, just to start with the facts, at least as I see them, because I've had a number of people on the show. The best evidence is, and the most hopeful is that a lot of this clears up with the long cases, 6 months, a year, which is a long time. You see continued clearing, and that's because, in part, I think it's because the vagus nerve system, essentially, which is most affected in a lot of these long COVID cases, takes the longest. It's the hardest part of the body to adjust. And I think the data would say that the chances, if you're vaccinated, of getting long COVID, however it's defined, I think probably defined as 6 months out, still experiencing some chronic symptoms, is about 5%. So look, it happened. 5%'s a lot. It happened to your wife. That's not nothing. But the other hopeful sign is we now have clinics set up. Mount Sinai has a great clinic. There's a bunch of other clinics being set up because we do know how to provide some treatment. But from a policy standpoint, we can't have our head in the sand. We need to be all over that. So yeah, you're right in that we should be thinking about the chronic elements of this disease, not the acute. And I know people who are past a year or a couple years and are having very altered states and existences, and it's no fun. It's hard for us all to calculate this, and that means that if you're informed, you're probably going to be a bit more conservative.
Value-based payment has been just around the corner for about 30 years, and Richard showed the data on how little of physician income and frankly hospital income is really based on value. We're still paid to keep the MRI humming and keep the beds full. And what do you think the future is, and why has it been so slow?
It depends how you look at Medicare Advantage, probably in that equation. I'm not sure how it's accounted for. But look, it's a regional cultural thing. And as we all know, culture is hard to change. These patterns are much stronger than some insurance company or CMS saying, "Hey, we're going to change the way we pay." Mm-hmm. And I think incentives are important. Don't hear me wrong, but I don't think incentives are what get people up out of bed in the morning. I think the best things you can do with these payment models is reinforce the good practice and good behavior, and say, "Hey, if you're doing these things right and well, and you're taking care of harder to treat patients, and more prevention, we will pay you more for that if you're investing resources in those things." But it's not a panacea. Mm-hmm. And healthcare's biggest problem is we've had a series of 20 or 30 silver bullets in the last couple of decades. This three-letter acronym is going to rescue us. This is going to be the thing that's going to, and it's not how it works in the real world. In the real world, you've got to respect the fact that there is something sacrosanct at the level of where care exists. And if you think you're going to be a marionette and say, we're going to change the way payment works and therefore transform everything, it doesn't quite work. And I think what evidence shows is the people who have been practicing kind of integrated team-based care and have been since before these payment models exist, when the payment models came in, they make more money. Mm-hmm. But it's not because they've changed things, it's because they're getting recognized. And practices that are dead-on fee-for-services practices or hospital systems, they're going to continue to do that and play that game. And things like ACOs, for many places, are not integrated care. They're market share acquisition tools. Mm-hmm. And so there's no other way, I believe, than changing culture and cultural leadership and focus on what people care about. And every time I go visit with CEOs, I will listen to what it is that they care about. And Triple Aim became this sort of very convenient place for people to land. And I think there's something better about it because it speaks to the spiritual mindset, and the Quadruple Aim probably more appropriately. But I knew what mattered to me, and every time I would go sit down and talk with a hospital CEO or a big practice CEO, and they'd say, we're improving Triple Aim, I would say, that's great. Here's my question. I want to know how the person who is in the bottom quartile of care and the person in the top quartile of care, how their care compares. Because if you're moving up the averages, but the waitress who lives 4 blocks away and the lawyer who lives miles away get very different care, then it's not working. And 100% of the time I would ask the same question. And now we talk about health equity. Now we talk about social determinants. Now we talk about these things. But you can't just create a payment model and say, care about health equity. You can tell when you walk in someplace, the people, to take care of hard to treat patients who have many things going on in their lives, which make their lives more challenging, poverty and other things. The physicians aren't going to do that because of a payment model. They're going to do that because
how does that not lead you to sort of policy fatalism to say that, even you carried the biggest lever of all, but the policies won't change if the culture or the leadership doesn't change, because how do you then get the culture and the leadership to change without the lever? It gets very circular very quickly.
It's part of the process. I mean, government, payers, all that. But it's such arrogance to think that you can sit there, whether in Washington or in Minnetonka, Minnesota, or in Hartford, Connecticut, or anywhere else, and say, we could flip some switches and change the way things work without really listening to and observing and understanding what's going on. And it's why change is slower. Now, by the way, there are examples, we could probably talk about a couple of them, where change happened relatively quickly. We hit COVID, and a lot of people who just said they can't adopt new technology were doing virtual care in a matter of days and weeks because their economics depended on it. And it turned out that they could do a lot more virtually than they thought. And so I do think we should push ourselves to think about how fast we can change, how fast we can transform. But the reason that worked is because it worked for patients and doctors, right? And so if you go give a doctor and patient something and say, do this, and by the way, it may be neutral to you, but it's good for everybody else, I don't know that that's a successful model. I don't think, when you put up Apple, Google, all these companies, they didn't get to be the best companies in the world because they were trying to persuade people to do something that they didn't have any interest in doing. They actually got to where they got because they understood the problems people have and figured out better ways to solve them. And that's a mentality that we, by and large, don't have in healthcare. And so that'll be the interesting thing about the Amazon acquisition and about others moving into the spaces. Can they bring that mentality in and keep it? Because if they can, it'll make us all better.
Yeah, we'll get to some of the tech stuff. Maybe last couple of questions, and I want to open up for a few minutes. Big Pharma just had a loss, which it almost never has in the public sphere. What do you make of that?
Big Pharma, NRA, and fossil fuel industry all had losses in the last 2 months that they have probably each spent 3 or 4 decades successfully fighting. And look, regardless of how you feel about those policies, and I would tell you that they're all important, the climate policy is far and away the most important in my opinion. But no matter how you feel about those policies, it is a encouraging sign for democracy. It is an encouraging sign that voters, because those policies, common sense gun safety, renewable energy, and affordable prescription drugs are wildly popular. I like to quote the statistic, but they're wildly popular, and yet for decades, hundreds of millions of dollars have been spent against them, which is in Washington still a lot of money. So I think it's a promising sign. I think, but the fight's not over. We're going to see all of those industries, particularly pharma, try to spend heavily to punish the people who voted for this, I think, quite modest, common sense piece of legislation that will help people. And I think they will talk apocryphally about how we will never have vaccines and R&D, and if people can't buy a biotech stock, knowing that you can charge $300,000 or $400,000 for your treatment if it gets approved, that they won't invest in biotech. And what I say, don't invest in biotech then. If that's what you need, if you need to have unlimited both volume and price, don't invest, go somewhere else. And by the way, why are we the only country in the world that will pay unlimited prices? So what this will do is it will, over time, it will strike and create some balance. My conversations with pharmaceutical CEOs are very encouraging on this topic, by and large, not entirely. There's some people who are very resistant, but they're very encouraging. And my conversations with the pharma lobby are equally discouraging. And this is the double-edged world we all get to live in, where CEOs get to talk a good game and pay their lobbyists to fight like hell against everything. That is what happens in a lot of these industries. Be magnanimous publicly, pay the other people to be the bad guys, and we just have to call it out. I mean, we really have to call it out. Policy making is difficult. There's no perfect answers, but big corporate interests being able to purchase or put a lock on democracy. And it's corporate, but it's also probably the lawyers' lobby and others. I mean, there's anybody being able to put a lock on policy is not a good thing.
Do you think when you see these three decisions and new policies in a package, do you think something seismic has changed, or it's just sort of coincidence?
I think it's been decades of work. I think it's been advocates. I think it's been people laying the groundwork. I think it's data. So it feels sudden. I think it's been a lot of people have done work into it. And by the way, as we know, sure as we took a step forward, or 2 steps forward, we'll take a step back.
Yeah.
Right. It's not smooth. I mean, we will see it continue to run that course. I think a lot like the Alabama decision. We will fight for a consensus and a happy medium, and so there's an enormous step backwards, Dobbs, but I do think it doesn't end there. Mm-hmm. And likewise, when you make something you consider to be progress, it feels good, but those forces, the pharma lobby and the gun lobby and all these, they have they're trained on one goal. That's their advantage. They're trained on one goal with lots of money, lots of resources, lots of focus, and as soon as everybody else loses his interest, they'll be back.
Maybe the last question that I'll open up. This is sort of a segue to some of the rest of the morning. When you heard about the Amazon purchase of One Medical, what went through your mind? Big deal? Not that big deal?
I think we need more competitors in healthcare. I think we need more innovation in healthcare. So, I know there's a lot of people cheer when, Apple lost hundreds of millions of dollars investing in healthcare. Hey, see, it's not so easy. People cheer when, Google does. My attitude's a bit different. I think, if you're United Health Group and you're scared of no one, and you've got basically, if not monopolies, large pieces of market share. I'd say that I'm an alum of that organization. They're very effective. Not picking on them, but it's not good. It's not good for us. And it's got to happen at the local level. So we need disruptors. Mm-hmm. We need disruptors to be successful. And I spend a lot of my time, we didn't talk about, but I spend a lot of my time funding companies that are trying to innovate in underserved communities and completely transform care delivery. And I feel like that's a good force that we need. If we talk only about policy in this country, and we see the world only through that lens, we get very rigid, slow, plodding movements. So why not take advantage of what we do well in this country, what we do uniquely well, and that's innovation. Mm-hmm. And people who have lived experience in communities and know how to deliver better models of social, behavioral, and physical care. We need them to open when people like Amazon who understand at a different way what drives people and will bring costs down, will manage supply chain, whether it's in prescription drugs or in primary care. That's good. And it's nice to be in a zone where some unanticipated things could happen, right? Mm-hmm. Because otherwise, this sort of consolidation thing that Richard talked about just all leads one direction. And we've already gone over the tipping point in consolidation. So you need things to shake it up.